Thank you, Mr. Chairman, and thank you all for being here with us today. And I share your concerns that came out of the VA OIG report. It does seem that the VHA has lost its focus on the primary mission of safe, quality care for our veterans. I want to focus in on this discussion about competition and get at the notion of veterans having choice, because in my district, I meet with veterans every time I go home, and just recently around these issues, we had a veterans roundtable to talk about the quality of care in New Hampshire. My veterans go to Manchester, to our Veterans Health Center, and also to White River Junction on the border with Vermont. And the question that came up was the one you've raised about going outside of the network. I was presuming that that was a logical conclusion, but the veterans actually that I spoke with want to have their care at the veterans facility. They feel more comfortable there. They feel that they're going to be better understood there. So my question is how, and I like this idea of the Medigap card. I'm interested in that. Beyond that, how can you use, and let's just start with you, Mr. McLean, about the TRICARE, when you're working with that network, what are the wait times there for someone that seeks an additional appointment?
Depending on what the specialty is or what the follow-up is, we can get them in within 30 days.
And that's similar, that's actually very similar to what it is in New Hampshire in the veteran system. I guess the question is, are there things that we could be doing with the facilities in terms of, one of the issues was about residencies brought up with Representative Titus. Are there other ancillary care providers? Could we be doing something? Is there something that you do in the private sector that we could be doing with nurse practitioners or people other? Because I agree with you, we need to focus in on that relationship with the patient and their healthcare provider. Can you give us examples of what we could be doing from the private sector? And maybe, Mr. Collard, do you have a suggestion on that?
Sure. A couple of quick fixes that have been mentioned in numerous testimonies is just the ability to recruit at a more rapid pace mid-level providers. If you take a look at the private sector folks whose names typically make the headlines, every single one of those folks today are talking about access to care. It's not a different issue. And one of the ways they accomplish improved access to care is through the provision of mid-level providers as that first wave of patient interaction, and it just, again, seems to work. The outcomes tend to be there.
Do you think it would make a difference to have a policy of alleviating debt for people who come out of medical school or other schools for healthcare providers, that they serve within the veterans system, and that we would alleviate that debt? Do you think that would make a difference?
Yeah, it's already been proven to work. Having operated hospitals in some of the most medically underserved counties in the United States, mostly the southeast United States, you know, we already have programs when residents will come and agree to practice in rural or underserved areas. That's a proven program. And I think this is no less noble a cause than for these veterans.
And that would certainly describe my district in their rural parts in the North Country. I'm very pleased, by the way, that we were working hard to get increased access to telemedicine for vets that have to travel. We have bad weather, mountains, such. But we also were successful in we'll be opening 2 new health clinics in Berlin and Colebrook in the northern parts of my district. I want to focus in on this issue about hiring, because one of the most troublesome things that I've heard about the VHA has to do with how positions are filled and that there's not a priority for clinic positions. I was shocked by that, that the leadership can make a decision about filling administrative positions. How can a surgery team operate and function at a high efficient level if they lose a nurse and that position isn't filled? What's your comment for any on the panel about the way positions are filled within the VHA, and how could we do better, and what's a policy that And this is the most bipartisan committee in the entire Congress. And trust me, we know a lot about institutions that do not function well. But we can function together, help us understand a policy that we could change about putting a priority on those clinical positions that are on the front line and filling those first.
So two quick things. I think it indicates the danger of levels of bureaucracy. The second point is behavior follows incentive. And so I bet if we looked at how folks are driven for performance reviews, et cetera, you would find perhaps not a disconnect between the ability to fill administrative position versus the ability to fill a clinical position.
And if we focus on those outcome measures rather than these process measures.
Well, the outcome is getting the physicians, the mid-levels, and the frontline caregivers in place as the outcome.
Right. I mean, if the outcome is good results, you're going to need to have those positions filled.
Yeah.